Okay, thanks for that, Ralph. So could you move to the next slide, please? Lovely. Thanks, everyone. So the idea of today, just to outline there on my first slide, is to give you a bit of a feel of a topic that no doubt all of you working between a paediatric and adult will clearly have a kind of working knowledge of. It's an area which is difficult when it came to kind of writing this presentation to be entirely clear how to give a fresh perspective, but I did reflect there are a couple of kind of angles on which we are kind of approaching transition, particularly with renewed energy in the HCC, and that derives from, first of all, conversations had at a high level between NHSE commissioners and our management teams, following on from the peer reviews at all three SHT centres, where transition always comes up as a topic that we all feel we wish we could do better. Obviously, many paediatricians in the audience will clearly be very familiar with this concept of transition between the paediatric and the adult service in many chronic illnesses, and sickle cell certainly a condition where it's very, very imperative to be thinking about. The other area or reason to be enthused about presenting on this topic today is some work done by an ex-registrar within the department who did some work with patients to try and get their sense of things from the patient angle, and put together a very nice poster for the ASCAP presentation, sorry, the ASCAP meeting last October. So we're kind of also pulling on data from Gaia, who I did acknowledge in the first slide that we quickly whipped by, but a certain amount of what I'm presenting here is pulled from some of her work on patient perspectives. So if we can just move on. So just to be clear on, what the agenda is today in terms of what transition is and why we should be talking about it. So this is the period of time between a younger child and a young adult, and their transition between the care needs of a paediatric patient and an adult patient is what we're kind of looking at here. And this is something that involves all of us, both paediatricians and adults. It provides the patient with skills to think about beginning to manage their own illness independently, and also is important in building their trust as individuals in our services and their ongoing engagement with healthcare as they reach adulthood, where obviously the dependence on parents and caregivers to bring them to clinic and help them take their medicines, etc., is beginning to kind of peel off a little, and they're left more independently to manage their own health. And so this is all inclusive kind of part of what we're trying to do, is not only give them the skill set to think about their illness and understand it better, but in many ways just help them understand kind of many aspects of what growing up is all about and the impact that that's going to have on their lives with the illness that they unfortunately suffer. So as far as pulling a little bit from what Gaia was kind of talking about in her recent work, we're obviously looking to raise awareness and empowering people by bringing them along on the ride of transition. It's not all about kind of the clinicians and healthcare professionals and what we want to do, but also want to feel as though the patients are part of this story. Clearly, they are the ones that we're catering towards, and it's important to hear their voices in the way we think about how transition works. Sorry, I just lost my slide there. Obviously, aiming high in the standards of care in all aspects of our work is important, but in this context, the idea that we want to deliver high quality care and reduce complications in the transition of patients from paediatrics to adult, where what we recognise is if this is done badly, transition is a period of time where you're at really quite high risk of a drop-off in patients attending clinics, and the DNA rates in the adult clinics are unfortunately higher than in the paediatric clinics, and that's largely kind of down to us giving the importance of attending the clinic to patients, and sometimes that's actually in the patients who are more mildly affected with their sickle condition, who might feel that there's very little that they gain from going to the clinic, and when their parents aren't there to persuade them to go, maybe begin to lose focus, and attention obviously goes elsewhere as they move from school to college, university, and the workplace, to kind of easy to miss appointments when you don't really feel as much necessity in attending. So that's something we want to put that message across, that the importance of attending clinic and being part of the service when it's up to them to attend. And finally, we'll allude to at the end of the talk how we might, as clinicians in the HCC and broader healthcare professional body, work towards unifying our approach to transition in ways that's possible and that I'm going to deal with, because I appreciate that's easier said than done in many ways. So if we can just move on. So drawing on some work done by Gaia, and I must kind of make clear, because it's fairly evident from the bar charts on the left, that despite Gaia's best efforts and a lot of work put into trying to engage the patients in participating in this, actually the numbers that were involved in her surveys and focus group were quite small. It was a difficult time, I think, for Gaia specifically in trying to kind of do this recruitment herself, and so she worked well with the patients who she was able to persuade into being involved. But basically what she did was set up some surveys in patients pre-transition and in some young adults in their post-transition phase, and talk to them about how transition had been for them, how well they felt prepared for the experience, and some of the thoughts that kind of came up, obviously reflected there in the picture on the right hand side, just that there was a general feeling of anxiety. And I think, this is obviously understandable for patients who have grown up in a paediatric setting, have become very familiar with the arrangements that they come to a clinic and see people that they know, very gently managed in the paediatric setting, and then move to something altogether different, maybe in a different location, possibly even in a different hospital, that feels a little bit kind of foreign. And I guess in some ways no great surprise what kind of has come out in some of her work there. We're obviously aware that young people with sickle, moreover than many other chronic illnesses, have a really high level of hospital admission rates, and really do need the support in feeling confident about the services that they're going to meet when they're not familiar with them. So if you just move to the next slide, please. So there are some summary kind of comments here from her focus group and survey work, just to focus upon. So as I've said, the idea for some patients certainly that adult care felt impersonal compared to what they were used to in paediatrics, that they have a high desire for speaking to patients, colleagues and I guess, peers who might understand better than maybe us professionals what they're going through. That's something we can come back to in the role of peer support in transition. There were some positive experiences reported, particularly in patients managed on daycare units, where they felt that the care was more personalised and their needs were more uniquely catered for. And again, perhaps not unsurprisingly, some of the more negative experiences were in the more generic non-specialist areas, such as in A&E or in medical wards, where it was felt that the needs of the patients weren't possibly attended to quite so nicely, and the knowledge of sickle cell was maybe less. This idea of being able to self-advocate and the vulnerability of patients, particularly when they're ill with acute crises, in managing when they're independently operating in hospital, was alluded to, and some of the worrying comments made around certain healthcare professionals being a bit dismissive or not really believing their needs, which we all kind of are aware of, is something we've got to be kind of conscious of educating colleagues about, who don't maybe work with sickle cell patients as much as maybe we do. But the use of certain language that can be stigmatizing and challenging for patients is also mentioned, and a lack of empathy, in some cases has led patients to query why they do engage with the healthcare services, and obviously worry that things like this might have implications down the line for engagement in follow-up care if patients have a bad experience on a hospital admission, and might begin to lose faith in the service. Okay, move to the next slide, please. So in preparation for kind of moving on to what we might be able to do better, I certainly don't mean to suggest that what we do within the Imperial SHT is by any means perfect, and I'm quite happy to pick some holes in the way that we run our adolescent service. And also I'm conscious that I'm speaking widely to an audience of colleagues working in LHTs as well as SHTs, and will allude to obviously the challenges that come from managing transition in hospitals where the resources aren't maybe as good. But there are, some aspects of our transition service that I'm very proud of and want to share. So we are in a fortunate position at Imperial to be able to offer a monthly adolescent transition clinic, which runs in the evenings So after school and college maybe are coming to a close, so it limits time missed in school, and maybe is slightly more convenient also for parents to bring their young people, or for young people indeed to appear independently. And I put a little asterisk around this because I'm very conscious that this is a kind of highly selected group of patients who are able to access this clinic. So it clearly kind of highlights the disparity, as I mentioned, between SHTs and LHTs, where the patients who are using St Mary's as their primary centre rather than their tertiary centre from an LHT are able to access this adolescent transition clinic naturally as a move from the paediatric clinic. We do attempt to bring in certain patients from LHTs who I go and do outreach clinics at some centres within the HCC, and those patients that identify who are clearly going to struggle with transition at the LHT level because of medical complexity are invited to come along to the Mary's Adolescent Clinic and join that. But that doesn't apply to all of the LHTs because we just clearly don't have capacity to bring all patients into this clinic. So there is a limit to that, and obviously is an issue of a lack of parity there between patients depending on their geographical location. So the transition clinic is attended by colleagues both from the paediatric SHT and adult SHT. So Hammersmith will be an adult consultant who will attend with a CNS, and we have increasingly now been able to welcome other colleagues into the meeting. So we now often will have a psychologist sitting in on the meeting, and sometimes somebody from the community CNS team also. So it really is a kind of quite a true MDT type clinic approach. It's been a great accolade to our service in the last 6 months to have finally a paediatric psychologist in place who really can focus on adolescent transition as one of her key areas where we obviously know there is a great need, and can act as a bridge to referring patients on to adult psychology when they come to the end of their time in paediatric care. We offer other referral options from the clinic, so the mention previously of peer support, so recruiting into peer support led by one of the community nurses who's able to talk enthusiastically about that to patients who want to hear a bit more, and we can help set that up. And other referrals to the adult dedicated social worker based at Hammersmith, and learning disability support if that's kind of warranted in terms of helping patients with learning disability needs advocate for themselves more easily. In addition to the work that we do in the transition clinic, which basically involves patients from the age of 14 up to 18, where we then begin to pass them on to the adult team once they finish their full-time education and move on to college or university or the workplace. I'm also conscious, obviously, of the growing number of patients who are on long-term apheresis who will also need their exchange transitioning over to the adult service. And it shouldn't be underestimated kind of how that's also quite a big change for patients. The practice of apheresis is somewhat different depending on kind of who's doing it. Clearly, being able to access the veins, getting used to the process and the new setup is an important one. And so we put kind of effort into trying to make that as streamlined as possible by inviting the patients to attend their first adult apheresis appointment with support from one of the paediatric specialist nurses who does their apheresis at St Mary's, so that they're able to attend with somebody who knows them well and can speak for them if they find that challenging. So that's something that, you know, we kind of can see there are some challenges with this transition process actually, because there is quite a backlog at the Hammersmith site for places in the apheresis service, and this is proving to create a little bit of a bottleneck insofar as a challenge in being able to get patients over from the paediatric to the adult setting, but that's something we're all working on. And the other area that we try to support patients with is in thinking about how their sickle cell care will be delivered when they move over to adults, if they're due to attend for if they're due to go to university and maybe move out of the London area. So we cater to that as best we can in the paediatric setting. Obviously, the adult colleagues take that on as well when patients move over, in the sense of trying to set them up not only with the transition to a West London adult centre, but also to a centre where they're based in the university term time. So what we tend to suggest is that patients keep their main basis of care in West London at the Hammersmith, in order to basically have somewhere kind of solid where they can come for appointments, maybe in the Christmas and summer holidays. But then they would also have term time care at their university town as well. So we put them in contact with the relevant clinicians for that. And then another area of need is, as I mentioned before, kind of just purely that need to kind of ensure that the patients attend the clinic in the first place. So this need to kind of be aware that at the point of making that first transition to the adult side, it's really important that the patients aren't lost to follow up at that stage. And so the adult CNSs who are very involved in following up these early recruits to the adult side are in regular communication with the patients when they are due to attend for their first clinic appointment, to try and make sure that they do get to those first clinic visits. And if that doesn't happen, then the adult CNS is in contact with the paediatric CNS, who obviously does know the patient well from previously, and we remain linked in to try and follow up on DNAs and ensure that the patients do attend these clinics, so that we're not losing patients to follow up. Next slide, please. So this is an area of focus in terms of one where I'm going to kind of be clear on what we could be doing better at Imperial, because I do feel that this is one particular part of transition that we're all kind of aware about. Clinicians will all, I'm sure, be familiar with the Ready Steady Go framework. So this is a generic framework that applies to all young people with chronic illnesses, so diabetes, epilepsy, etc. And basically is formed by a variety of guided questionnaires that the patients are encouraged to complete with maybe the support of healthcare professionals over the course of the transition period. So reading the website in preparation for this talk, the ideal thing is that these documents are used generously throughout that kind of transition time from the age of 14 up to 18, and the different questionnaires are built upon in subsequent years, so that the initial Ready questionnaire is done when you're quite young, and it basically explores a variety of different areas of teenage life, not just knowledge of the disease, although clearly that's important, but other aspects of understanding one's own health and what's important in lifestyle, daily living, aspects of education and leisure, thinking about mental health and so on. Sorry, I'm really distracted because I keep on getting a phone call. What I'm going to do is just for 2 minutes is just hold you, and then I'm going to answer this phone call, else they'll stop ringing me. I'm really, really sorry.
Apologies all. Hopefully Kirsten will rejoin the meeting/presentation shortly.
I'm back.
Okay.
I'm back. I'm really sorry, Ralph, but I was having someone knock on my door and then somebody ringing me, and I just couldn't stop and I couldn't concentrate. Now I can. Sorry, everyone. Okay, so where was I? So basically, this idea of these questionnaires and when they need to be delivered, I feel that what probably happens in our service, if I'm entirely honest, is that we resort to Ready Steady Go probably a little bit too late in the process, and we're generally very good at doing the questionnaires in the last year before the young people are due to move on to the adult service, but probably don't employ it well enough in the run-up period. So, being aware that these questionnaires are supposed to be used for several years in the lead up to transition, I don't think really happens as effectively as it could do. And maybe with a kind of support of additional colleagues such as our psychologists and now more nursing support in these clinics, we're now better positioned to be able to do the surveys and build the knowledge from a younger age. The idea of the Ready Steady Go transition tool is that by the end of the transition period, a good kind of sense, obviously, of the patient has been developed, and allows a bespoke transition plan to be put together that then should be handed over to the new service with the patient's buy-in as to exactly what they feel will be important for them at the point that they move over to the adult service. So this is something that, I think we all, looking at a survey I'm about to allude to across the HCC, we do, I think, all use the Ready Steady Go framework quite well, but kind of quite how deeply we get into using it in a sense of throughout that entire transition is maybe. Sorry, I'm getting some feedback. Maybe something we could all kind of think about whether we are in a position to be able to do that slightly better. If you could move to the next slide, please. So, whilst I'll speak kind of positively about the Ready Steady Go tool, I think it's important to make reference to this other alternative tool which is being employed at the Evelina and has been copyrighted, and I think will be soon, if not already, published and more broadly offered as an option for transition in sickle patients. So the Ready Steady Go tool, as I mentioned, is a generic tool. It doesn't specifically allude to the needs of sickle cell patients. What the colleagues at the Evelina have done in creating this specific tool is basically taking various aspects of the Ready Steady Go framework and applying that specifically to some guided questions about sickle cell. And so what, just in brief, the Evelina tool does is basically takes 10 broad sections, and both the healthcare professional, maybe the specialist nurse, and the patient take time to answer the questions, and they're given specific scores. So I think the Ready Steady Go tool doesn't kind of have final scores, and that doesn't matter too much, but this particular tool does. So each question is given a maximum score of 10, and the patients work their way through those questionnaires with the healthcare professional, and scores are given at various time points, and the areas of kind of unmet need in terms of where lower scores are charted are obviously seen as areas of gaps in knowledge or where work could be done to further prepare the young person for their sickle transition. And so then, in a similar fashion to Ready Steady Go, these questionnaires are repeated as the patient gets older, and obviously one hopes the scores get higher as they move towards their adult transition. So having kind of discussed this with colleagues kind of internally, I think there's a feeling that Ready Steady Go is working well. This isn't offering anything too novel, really, apart from making maybe the young person feel that this is more targeted to their specific needs as sickle patients. But I think either tool kind of has its place, and I guess it's all to do with what people feel comfortable with, and maybe the Ready Steady Go is preferred on the basis of its familiarity. But I just wanted to mention that this tool does exist. Next slide, please. So, in moving kind of towards a more broad conclusion about what we might be doing what we might be thinking about as an HCC doing better, the other piece of work that was actually undertaken by Ralph in anticipation of more broadly thinking about transition across our network was a brief survey, just a kind of snapshot assessment across colleagues in both SHTs and LHTs as to what they were doing with regards to transition. And so there's some fairly simple kind of questions, but just gives you a little summary here of what is happening. So fairly kind of clear to see, as I mentioned, that Ready Steady Go seems to be well employed by most trusts, but there is a kind of acknowledgement that maybe specific pathways with regards to transition are lacking, and that certainly is not going to be no great surprise to people. Having designated staff members to guide and help with transition is also an issue. There's a lack of time, I think, and that is certainly something we will all be familiar with in being able to kind of set up specific clinics in certain trusts. So there are transition clinics across all sites, and peer support, kind of access to peer support or knowing how to refer to peer support, also seemed to be something that wasn't happening widely in all centres. Next slide, please. So I guess what I was thinking I'd do in trying to kind of bring together some thoughts about how we might approach transition as a wider group, and I think it's obviously difficult because we're all very heterogeneous in our setups in our different hospitals. We cover clearly a very wide geographical area, and it's hard to bring people together when people are kind of time limited, and there are lack of resources in terms of maybe nursing and other allied healthcare professional support. What I thought I'd do is just, by defining this kind of little pictogram, just make clear that I think sometimes there is a sense from the paediatric side that transition is all about what we do in paediatrics, because obviously we're the ones who have the patients under our care at the outset and therefore take a lead clearly in starting the transition process. But I've spoken to people informally, and the message is made again and again by colleagues in paediatrics that there's clearly a real need for all colleagues across all these 4 groups, both the paediatric and the adult colleagues in the LHTs and the SHTs, to take equal responsibility in playing a part in doing transition well. And where I've put kind of ticks and question marks, and I'm aware there are colleagues from some of the LHT sites in the call, and I certainly don't mean to offend anybody in kind of making my kind of pictogram here, but ultimately I guess what we know kind of from discussions we have that we are obviously able to do within the paediatric side and the SHT side is clearly because we're better resourced and we kind of have more availability to cater to the needs of our patients, where patients in LHTs, particularly I think often the adult setting, who are sometimes kind of really have everything kind of stacked up against them, aren't going to have the same time and resources to be involved in this process. But it's just trying to work out ways that we can all feel that all of our voices are coming into the picture together when it comes to transition, and that we're able to do our best to help these young people. So I'm kind of aware, I mean, there are clearly clinics going on at the LHTs where paediatric and adult colleagues come together independently of our SHT teams to manage transition. I know of those types of clinics, but they're not happening everywhere. And equally, the involvement of the adult LHTs in inputting into the adult SHTs is also an area, I think, of some unmet need. And that's obviously challenging if we can't all come together and discuss this. And I guess I was hoping that there might be more clinicians in the meeting today to be able to give points. I'm sure we'll have some questions, but it's clearly just by virtue of the fact that everyone's so busy that people can't come to these meetings and get involved in these discussions. Other factors that are problematic in thinking about transition on a HCC level are the fact that the transition age in different hospitals is different. So this notion that you want to transition your patient when they get to the end of their education, their full-time education at the age of 18, that's not a luxury that many LHTs have. Many are pressured by the fact that the A&E transitions patients at the age of 16 between paediatric and adult, and that almost forces our arm slightly. If you have that transition happening at the age of 16, it's very difficult, even if paediatric departments were keen to keep the patients until they were 18, that's just not feasible. And so what's sometimes happening is that the young people are being transitioned at the LHT level at the age of 16 to their adult team, but they're not transitioned at the SHT level until they're 18. So that disparity clearly stands in the way of us all working together at doing some unified process when there's obviously transition happening at different stages in different hospitals. So that's one thing. Time pressure I've talked about, even to be fair, physical pressure of actually finding clinic space to get a big team together to have a transition clinic might make that not a feasible option. As mentioned before, the lack of specialist nurse support in the LHTs is a huge issue, and not something that we can easily fix, but is standing in the way of people having the time to do some of the transition work. And I think what also should be referenced is the fact that not all patients are the same, and not all patients' needs are the same. Whilst it's important that every young person understands what transition is, and that they have kind of all a certain amount of attention put into doing that, there are going to be some where this is going to be a lot more difficult than others. And so some patients who are more medically complex or have higher psychological needs and more anxiety about transition are going to need a broader and longer period maybe of transition than somebody who very happily kind of feels that they're grown up and ready to go to the adult service. And so there needs to be something of a bespoke kind of process for each patient. Next slide, please. So just bringing things to an end, this is the final slide before maybe opening to some questions. As an HCC, what we tried to do, and I'm afraid I'll be honest that this has met some challenges due to pressures at SHT level with various staff leaving and not being able to attend these meetings. We attempted to set up a working group of colleagues where we invited colleagues also from the LHTs to think about attending, to talk about how we might work towards some degree of consensus in the way we think about transition. I think it might be naive to envisage that we can simply put together a guideline on this, because I think that guidelines are quite prescriptive and limit what people have in the way of flexibility within different services. So the idea of having some kind of consensus where there are just aspects that we can realistically work towards in standardizing some of our approaches towards transition might be worthwhile. And one thing that came up in one of our workshops on this topic was whether at the very least we should be aiming towards having some kind of MDT discussion between the different colleagues in the four sectors of care, so paediatric, adult, LHT, SHT, around patients. So even at minimum to have had a chat about them on a Teams meeting to provide some kind of handover across site between the teams would be a useful way of feeling that we've done something. Clearly, the ideal thing is that there's a transition clinic for every patient and that's able to be an option. But in absence of that, some kind of MDT discussion we thought was worth suggesting. And obviously there's more that we can talk about in terms of how we might come to other consensus, for example, in the way that we use Ready Steady Go maybe, or whether we choose to adopt the Evelina sickle transition questionnaire instead. These are kind of aspects that we might all be able to come to agreement on. As mentioned, the issue of staffing and the lack of staffing standing in our way, this is something that obviously just needs to be reported up the chain. And I know Ralph is more than aware of the challenges that are inherently present in the LHTs in the absence of specialist nurses. But there's a lot of work, as we'll know, going into community nurse support, and a focus in transition is also key in that regard. And obviously also in broader work with recruiting colleagues in areas such as psychology, social work, youth work, etc. There's other work that's going on more broadly across London that we're trying to kind of get a little bit involved, at least on the sidelines. So Andrea Lee at UCLH has set up a kind of national group for people interested in talking more about how transition might all be something we can work on collectively, and with a particular focus maybe in trying to work on how we might engage young people more socially in forum that they can join. So there was talk about a kind of online youth group, support groups that can be kind of offered not just within a particular HCC, but kind of across a wider patch, and that might just be able to be kind of better maintained if it's got more young people in it and more colleagues kind of willing to input a little bit of time. So that's something to be aware of. And one thing was mentioned actually by our psychologist since starting in post is also the idea of setting up cross-specialty links with other colleagues who work with children with other or young people with other chronic illnesses, and maybe looking into whether youth kind of groups and support groups for patients more broadly in transition with different illnesses might also be something that's worth thinking about. So there's a lot there, I'm aware, and clearly a lot of things that we're not kind of ultimately within our control to kind of make right immediately, but there's a lot to aspire towards in trying to make this process better for our young people. And obviously want to end by saying, as mentioned in the early part of the talk, bringing the patients into that discussion as well is really key, and coming back to kind of asking them what works for them is going to be an important part of making this process work better. So I'll finish there and happy to try and answer any questions. Thank you.
Thank you, Kirsten. Does anyone have any immediate questions for Kirsten? Asad.
Yeah, hi, thanks, Kirsten, for that talk. I was just wondering, would it be worth mentioning the fact that we do the transition tours?
Sorry.
And
yes.
what
yes.
and what feedback you've had and how useful they are.
Yeah, apologies. That would have been a really obvious thing to put in the talk, wouldn't it? Yes, so this is something that we've kind of engaged in the past couple of years in trying to do at Imperial, where twice a year during kind of half-term breaks we invite young people and their families from the St Mary's site to go over to Hammersmith for a tour of the department, meeting kind of key colleagues who then give kind of little presentation. There's generally some food as well, and there's an opportunity to kind of see various aspects of the hospital. I think we're quite conscious with Imperial being split across 2 or 3 hospital sites that young people obviously have that extra barrier of actually having to find a new hospital location to attend their first clinic, and maybe better that their first visit isn't when they come in for their first pain episode or their first clinic, but actually that they've come over before that. So yeah, I mean, I think in terms of informal feedback that I've had, largely kind of often coming from parents rather than the young people, but I've never had anyone who's not felt that that's been a useful thing to do. Just in terms of just feeling that the staff become a little bit more familiar, and I guess if these young people have been going to the adolescent clinics, some of the staff, they will already know a little bit, but I think it's widely been recognised as being a good thing to offer that. Thanks, Asad.
And Kirsten, just to check, how far in advance do you let the patients know about it? Is there a kind of general setup, and how well has it been attended, or do you send it out to a large group of patients, or do you try and look at who's going to come up to transition and try and target them with messaging?
Yeah, so I think we kind of start to approach the idea of coming on the tour when there's about a year to go before the patient's due to move on, maybe. I mean, there is some variability in this transition, I must say, because whilst I kind of say realistically you're aiming to kind of get somebody moved over to the adult service when they're reaching the end of their education in the schooling system, some patients who are leaving our service are indeed in even a little bit further on than that, because some will turn 18 very early on in the year, clearly academically, and almost be 19 by the time they're due to move over. So there's a little bit of flexibility in when they make that move, but as far as when to offer the tour, I think we want to give them an opportunity to have at least 2, if not 3 tours, in case they can't attend one. Clearly, if they're heading towards exams, it can be a little bit challenging. So we kind of talk about roughly when they sit these tours, and we tend to kind of try and do them so we're doing them the October half term, the February half term, so they're kind of hopefully done their mocks by the time that the tour's on offer and that they're not about to sit their exams. But yeah, it's often a question of offering widely, knowing that we're not going to have the take up of everyone we offer the tour to. And I think yes, these things are a bit variable in how well people attend. There've been certainly some that have been better than others, and occasionally parents will attend without the young person, and then we've had kind of young people arrive by themselves subsequently, after their parents have been on the tour. So I think as long as there's enough people to make it worthwhile running, we tend to kind of get enough people to do them twice a year.
Do we have any understanding of how stark the difference between the DNA rates in pediatrics and adults are? And does that maintain, or is it just specifically around the adult or adolescent patient group? So i.e. when people get into their kind of 20s and 30s, does that drop at all? Do you know?
I wonder whether that's a question for Asad and Stephen, isn't it, if they're looking at their DNA rates in their adult clinics, because that's not something that I'd be specifically looking at. But I mean, it would be interesting to know, having said all the stuff I said about how keen we are to try and avoid DNAs, I know Stephen will make mention from time to time about people who do drop off the clinic, but I don't know that either of them are still available to answer that.
Yeah, no, I've seen a few patients as well who I think a few that don't come for their adult appointments, and we need to keep chasing them. And then a few who come for their first 1 or 2 appointments, and then they kind of keep DNAing for their appointments. So yeah, we do see a few patients who stop attending.